I'm Dr. Tom Cheatham, a family physician, and this is a series of 4 brief presentations on how to get the most from a medical appointment, trying to understand the reality of healthcare practice so that people with disabilities and caregivers, families, and others can be effective partners together with their primary care provider. So this second part is what information is needed. Again, one of the Clinical Pearl series on our website. So the 4 topics, and the first one was understanding the reality of the time for a medical appointment. This is number 2, and then we'll talk about how can you keep track of all that information and record it for the provider. And then the last one in this series is tips. So if you want to look at some objectives, I've listed them here. That's really just to outline what things we'll cover. And it's worth emphasizing in this particular episode that we're not trying to make you into healthcare practitioners here, but simply understand the importance of the process. And we've talked about the importance of history, which most people don't recognize. Most of the information I need for a diagnosis comes from history. And then you see the other things that you'll learn here, what type of information, barriers we've talked about. And at the end of this session, I want you to be able to, in just one sentence, present a summary of why you're here when you come to the provider. The medical database, the information I need, is like a language, a new language, and to many people it's going to feel like a foreign language. It does to medical students at the beginning of their training. And so, as we've talked about in the previous episode, there's only really 3 things in terms of information I have: history, examination of the person, and then tests or investigations that I do. All of that information goes together to form a diagnosis, and from the diagnosis, a treatment plan or plan of care. We use a problem-oriented approach, and it's called the SOAP format. So subjective information is the history, what the person tells me. Objective is what I find from examining the person and the results of any tests. And then the assessment is the diagnosis, and P is the plan. So you'll see sometimes in copies of information you may take back to the agency or keep at home the headings of SOAP. So the medical history, it's a roadmap, it's a language, as I mentioned. It's a way to organize the information that all clinicians learn and use. And it's a way of thinking. And as I've highlighted in the first episode, it's also 70 to 80% of the information needed for diagnosis. So, what information is included here in the history? Here you see an outline, and there's a lot of it, and I'm going to just unpack this briefly with a real emphasis on the first part, the presenting problem, also sometimes called the chief complaint. We talk about complaint in a way that isn't used in normal language, and that's part of this foreign language physicians and nurse practitioners use. We have evidence that if you come into me as your provider, if you don't engage with me quickly, like within the first 30 seconds, I'm going to jump in and start asking you questions, and that's not what you want. So that's why I've highlighted here how you should open after an initial greeting, hello, and so on. When you start to get to the information, there's a way to present it that will be much more engaging to your provider. And so the chief complaint answers why you're here, or why you're here now, what made you seek attention right now. That needs to be one sentence, and even if you see me a lot, I'm seeing a lot of people every 10 minutes or so. I'm switching from problems to different people, and it's challenging over a whole day. So give me a little break and provide me information that I likely know, but it's really helpful to remind me. So name, age, and why you're here. So, hi, Dr. So-and-so, we're here. and assuming this is a person accompanying the person. Remember, John's a 46-year-old man, and he's been vomiting for 2 days. So in that short phrase, the provider's already starting to think about possible diagnoses. However, it's a little more complicated with people with disabilities because although not every provider is going to know what is implied by the technical term of mild or moderate or severe profound level of disability, that's something you can help educate people. And it implies significant information to someone who knows. So add a statement about the disability. So, hello, Dr. So-and-so, I'm here with John. Remember, he's a 46-year-old man with a severe intellectual disability who's been vomiting for 2 days. So in that sentence, you've set the tone for that visit. If you know the cause, and again, depending upon the experience and the training of the primary care provider, that may have more meaning for some than others, but it is important information. So if you know that, that's also worth including in that initial statement. So, building on the example, John's a 46-year-old man with severe intellectual disability and Fragile X syndrome who's been vomiting for 2 days. Or Mary's a 28-year-old woman with Down syndrome and a moderate intellectual disability who's here for annual checkup. So, you've set the tone of that appointment very quickly at the very beginning. And there are just a couple of other examples for you in terms of one sentence to include all of that information. And if the cause of the disability is not known, that's worth stating as well. Hopefully you get the sense of that and try practicing just so you feel a little more comfortable doing that. So, chief complaint, why are you here? History of present illness, the second point is tell me all about it, but tell me all about it really quickly and just the essential features. So it's a more complete description, and it may not always be necessary, but there's confusion between signs and symptoms. Signs are what I observe. Symptoms are what you, the person, has. So in a way, subjective and objective. So here's an example, and I'm not going to go through all of this, but it's an example of pain, and we do know that pain is often problematic for adults with intellectual disabilities because they don't show the same pain behavior that we might. And although extremely rare, some unusual situations occur, such as people walking on a fractured hip or having very, very severe health issues and appearing reasonably well that would be impossible for you or I. So if the issue is pain, where is it? Does it go anywhere? To tell me that the person has a pain in their right stomach, their right abdomen, and it goes to their shoulder blade already gives me a shorter list of things I'm looking for. What's the type of pain? A burning pain implies a certain cause compared to a pressure or squeezing. When did it start? Did it come on suddenly and it was full-blown, or did it come on gradually and build up and then ease off and come back again? When does it come? Are there certain triggers? Are there any things you figured out or have observed and inferred, if the person can't describe that to you, that makes it better or makes it worse? Are there any other things that seem to go with it? Nausea or vomiting, or the person seems like they're dizzy. And if the person has limited verbal communication, tell me about the behavior that you think implies certain things so I can help make up my mind as well to verify your observation. So those are the elements that are important for pain. Past medical history is still history, so have there been any serious illnesses? Are the person's shots up to date, their immunizations up to date? Do we know about their developmental history? That can be helpful. What about behavior and psychiatric history? They've been in hospital. Usually that implies a significant issue. And if they had any surgery. If I know somebody's had their appendix out and they have pain in the right place for appendicitis, that becomes very less likely, and so that's very helpful. Or if the person's had extensive surgery and they're vomiting, they may have adhesions, they may have scar tissue that is causing problems. So each of these elements can be very helpful for me as I work through possible diagnoses. The more detail on the developmental history, the better. What about prenatal, substance use, smoking, weight gain, any problems mother had during the pregnancy? How was the time before the delivery? You know, was there high blood pressure? Was she in hospital? Developmental milestones after the delivery, and school performance all can be helpful. But just very briefly, because as you see already, there's a lot of information here. And then behavioral and psychiatric history, hospitalizations and surgery, as I've mentioned. Allergies are very important, and allergies can be to medications, to foods, or they can be environmental. Now, a word of caution, because we often talk about allergies in a loose way, and I must admit I do that too sometimes. We sometimes confuse side effects from allergies. Now, if we can sort that out, that's helpful, but both could be reasons why I wouldn't want to repeat a medication. So somebody being very constipated from a pain medication is not an allergy, it's a known side effect, or drowsiness, that sort of thing. Medications, clearly there are huge issues with medications in people with intellectual disabilities, and the kind of information we need is listed here. The more detail, the better. Time, the person was tried on a medication that wasn't effective. That's helpful. I'm not going to try something if I've got a good history that it wasn't effective. But if somebody says, well, they were tried on, for example, this antidepressant for 2 weeks and it didn't work, that's helpful information, because we know that many antidepressants will take 6 weeks or more to become effective. So that was not an adequate trial, and it might be an appropriate drug to use. So that's why the detail is very helpful. Side effects, I should mention, often go away if the person can, if they're not too severe at the beginning, because our bodies are good at adjusting, and so initial drowsiness and some problems can get better as the person is on a medication, at least with some medications, as they're on them longer. Family history, you know, things can run in family, and so the closer the relative is, the better. Parents, siblings, grandparents, but then there's a sort of second level of other family members. It's helpful to know their age, any health problems, and if they're deceased, how old were they? You know, somebody who died in their 20s is certainly very different from somebody who died in their 70s, and it's helpful to know what was the cause of that relative's death. Psychosocial history in the general population usually involves, do you smoke? What about employment? What about substance use? We need to expand that, and providers may not even know they need to expand that to get a more complete picture of the person with disabilities. The psychosocial history is sometimes called the patient profile, and again, I've listed a number of things here. The first two points really would be similar to anyone, but in terms of educating the provider you're working with, a word about living arrangements and day and leisure activities of the person will help them understand a little bit more about this individual with a disability. It's helpful to remind them about communication skills, and remember that I may talk very well, so my expressive language may be very good, but my receptive language, my understanding what you're saying, may not match that, and there may be a disconnect, or vice versa. And then what about my ADLs, my daily living skills, activities of daily living? Again, brief and to the point. And then review of systems, also called functional inquiry, is a series of questions I'm going to ask to make sure I haven't missed anything. And typically I'll start at the head and work down to the feet. You know, headaches. What about eyes, hearing, any nasal problems, dental, and all the way down. One way to get a sense of that is to look on the IDD Toolkit website at the Health Watch tables, because essentially they are functional inquiries for those genetic syndromes for which there is a Health Watch table. So I'm sure at this point you're asking, how on earth am I going to remember all of this? And I'm glad you asked that, because that leads us into the next section, a way of organizing it and keeping track of this. Thank you very much.